Alright guys, I'm so proud to say that the last video worked, so we're going to go ahead with chapter 22 and get this going. So I'm very excited it's working for me. I'm sure you're probably not as excited as I am, but that's okay. So chapter 22 is going to be covering care of patients with cancer. Some consequences of cancer are going to be motor and sensory deficits. Those are going to be, can be pretty severe. So, for instance, a patient that has cancer that has metastasized to the bone, that's really going to cause a lot of pain for them, fractures, hypercalcemia, and potentially spinal cord compression, which may alter their sensation. Something else that's really important to remember with these patients that have metastasis to the bone is going to be safety precautions for them. So you want to make sure, we'll talk about safety precautions a little bit later, I think, with thrombocytopenia, and it's kind of the same thing. So you want to make sure that they've got good shoes on before you get them up and ambulate them. You want to make sure you're using a gait belt. Using the chuck when you're raising them up in the bed or a draw sheet, things like that to really prevent pain and also to prevent injury to them. Another consequence may be that respiratory function is impaired. The gas exchange can be disrupted. So tumors can cause airway obstruction, decreased lung capacity, and they can also decrease blood flow, which results in pulmonary edema and dyspnea. So, different types of surgery that can be used with cancer. You can have surgery to remove potential at-risk tissue, to diagnose, to cure, reduce the number of cancer cells, improve quality of life, which would be considered palliative surgery, determine treatment and effects of treatment, and reconstruct the body after cancer removal. So, radiation, the purpose of radiation is going to be to destroy cancer cells. Effects are seen only in the tissues that are in the direct path of the beam. It is given as a series of divided doses. Why is that? Well, it is given as divided doses because, for a couple of reasons really, because of the varying responses of all cancer cells within one tumor, so that's one reason. Most often, small doses of radiation are given on a daily basis for a set amount of time to allow greater destruction of the cancer cells while also reducing damage to normal tissues. So it kind of breaks it up a little bit. So what's the goal of radiation? It's to kill cancer cells and leave the good cells as much as possible. There are two different types of radiation. They are teletherapy and brachytherapy. So teletherapy is also known as beam radiation. It is a distant treatment that is external to the patient. The patient is not radioactive with this type of treatment. They must be in the same position for all treatments, so it's very important to ensure before you arrange this radiation therapy that you know that the patient will be able to tolerate being in that specific position daily for all of their treatments. Effects of the radiation are only going to be seen in the tissues that are in the path of the beam. So the patient is only going to lose their hair and have skin changes in the area that is being radiated. Some teaching for radiation: you're going to have the patient wash daily with soap and water unless otherwise advised due to the markings. You do not want them to remove the markings. Obviously, that's very important. You may need to use, to teach them to use their hand to wash themselves instead of a cloth. They need to rinse thoroughly. No powders, lotions, or ointments unless they are prescribed. They need to wear soft clothing and avoid belts, buckles, or straps that are going to irritate their skin. Avoid exposure to the sun and avoid heat exposure. So for brachytherapy, that is considered short or close to therapy. The radiation comes in direct continuous contact with tumor tissues. It does provide a high dose of radiation to the tumor but limits the dose to the surrounding tissue. With all types of brachytherapy, radiation is within the patient, and the patient will emit radiation and is a hazard to others with some of this. Very important to remember. So, unsealed radiation sources, these are going to be given IV, PO, or as an installation into a body cavity. An example of this is going to be the injection of radionuclide iodine to treat thyroid cancer. So, the radioactive iodine concentrates in the thyroid gland and it destroys those cancer cells that are there. It is eventually eliminated in waste products. Important to know. Most isotopes are eliminated within 72 hours. There's actually differing data on that. I did a little bit of research. It's anywhere from 48 to 96, but on average and most commonly, it's going to be 72 hours. Once the isotope is eliminated from the body, neither the patient nor their waste are radioactive. So sealed radiation sources, these are going to be implanted within or near the tumor. Some devices will stay in place by themselves while others have to be held in place by another device. With these, the patient will emit radiation while the source is implanted, but their waste products are not radioactive. So, for care of patients with sealed radioactive implants, very important, obviously, they're going to have a private room. They will have a sign on the door notifying of radiation. You will want to keep that door closed as much as possible. You're going to wear a badge to monitor your exposure. Really important to think about this, guys. Do not share that badge, because obviously it's not going to be accurate if you're sharing it with somebody else. Make sure you wear a lead apron and do not turn your back to the patient because that exposes you to the radiation. Limit visitors to 30 minutes per day or as your policy guides you. Very important, guys. Never, ever, ever touch the implant. Always, always use long-handled forceps to pick it up. So whether it is you're expected to be dealing with the implant, whether it unexpectedly comes out of the patient, whatever the case is, no matter what, don't touch the implant. Use those forceps. You're going to dispose of it in an appropriate container, and you are going to dispose of linens properly. Oftentimes what they'll do is they will keep the linens in the patient's room while they are radioactive, and they will bag them up and get rid of them properly either once they're discharged or once they are no longer radioactive. There is a chart on page 376. It's chart 22-1 that kind of goes more in depth to these things. So, some side effects of radiation are going to include altered taste sensation, difficulty swallowing, fatigue, fibrosis or scarring, skin changes, hair loss, xerostomia, and tooth decay. So, oral care is obviously very important for these patients. The xerostomia is going to be when they lose all that moisture in their mouth, they don't have any saliva, which contributes to the tooth decay. So, not only can it cause problems just from having the dry mouth, but it's also going to cause problems to your teeth. Oral care is very important. So for chemotherapy, it is used to cure and increase the patient's survival time. It has some selectivity to kill cancer cells over normal cells. Chemo destroys rapidly dividing cells, so that's why it's useful with certain cancers because some tumors rapidly divide. However, because it does attack rapidly dividing cells, it also will attack normal cells that rapidly divide. Those may include cells that are in the skin, hair, intestines, spermatocytes, and blood-forming cells. So this is why patients receiving chemo lose their hair. They have problems with eating, and then they also develop mouth sores. Different categories of chemo. I don't expect you guys to know these. Again, this is just a general overview. So anti-metabolites, those are going to be counterfeit metabolites. They function as regular metabolites, so the cell division does get impaired. So what happens is it functions as a regular metabolite, tricks the cancer into thinking it's a regular metabolite. So the cancer cell will absorb it, and then it interrupts the cell division of the cancer cell. Anti-tumor antibiotics, those are going to damage the cell's DNA and also interrupt DNA or RNA synthesis. Antimitotic agents are going to interrupt cell division. Alkylating agents inhibit cell division. And then topoisomerase is going to interfere with DNA maintenance, which causes cell death. And I probably just butchered that category. Sorry, that's the best way I could pronounce it. Okay, so what is combination chemotherapy? Combination chemotherapy involves giving more than one specific anti-cancer drug in a timed manner. So how does this relate to the nadir? The nadir is going to be the time when bone marrow activity and white blood cell counts are lowest after chemo. Combination chemo uses drugs that have different nadirs so that it reduces immunosuppression. The dosage of chemo and medication is going to be based on the type of cancer and the patient. Chemo can be given IV, oral, intra-arterial, isolated limb perfusion, and in a specific cavity. So, chemo is given at timed intervals. This is going to allow it to let those normal cells have a recovery period while also ensuring that the cancer cells do not have enough time to recover. So, a major complication with the administration of chemo drugs IV is going to be extravasation. Any med that causes tissue damage with direct contact of the skin is always going to be called a vesicant. So, symptoms of extravasation are going to be pain, infection, and tissue loss. Obviously, very, very, very important to prevent this from ever happening. Treatment is going to be dependent upon the drug that is administered. There are sometimes specific antidotes that are available. Treatment may include cold or warm compresses depending on the drug. So, what are we going to do first if the patient complains of pain at the site? Most important thing, prevention, right? So we're going to stop that IV. Figure 22-2 on page 379, shows an image of extravasation. And interestingly, when I was reading the chapter, it talked about the amount of fluid. So very interesting, just a side note, but it said less than half a mil of drug leaking into the tissue can usually resolve without any kind of extensive treatment. However, if it is more than half a mil, which is nothing, guys, if it's more than half a mil that has leaked into the tissue, it causes extensive tissue damage and it may require surgery. So, obviously, an important intervention for these guys is going to be to monitor that IV very, very closely. So, how do we chart when extravasation occurs? We're going to document the date and time of the occurrence, when the infusion was started, stopped, the medication, the amount of medication infused, needle size, method of administration, and site of extravasation. You're also going to want to document when the last time you checked for blood return was. Take a picture of the site, and of course document your interventions. So something that's really important about this is in addition to documenting on the nurse's notes, it is very important to take a picture of the site, and also you can mark the area because that's going to help promote continuity of care, and it's also going to allow people following you to see, you know, is this getting worse? Is it resolving? Kind of judge the care and interventions based on that. So these next few slides are just going to be a couple of pictures of sites that have infiltrated. Obviously does not look like a very fun experience. So when it comes to administering chemo, should a nurse administer chemo who has never been trained? Why or why not? Absolutely not, guys. I'm sure you knew that. Competence is really important when it comes to administering these meds. And so these chemo-trained nurses are going to be aware of the indications, doses, side effects, adverse effects, schedules, and precautions for the drugs. Obviously, someone that has not been certified in chemo treatment is not going to be competent. So do not administer chemo if you have not been trained. Simple as that. Use extreme caution and wear protective clothing whenever preparing, giving, or disposing of chemo. An important side note, can chemo be absorbed through the skin? Absolutely it can. Something else that I read in the text that I found interesting, makes perfect sense. I just hadn't really thought about it before. PO chemo is just as toxic to the nurse as IV chemo, so it doesn't matter what kind of preparation you're handling, you're obviously going to need to make sure you have that PPE in place. So some side effects of chemo, going to be hair loss, nausea, vomiting, sores on the mucous membranes, anxiety, sleep disturbances, altered bowel elimination, decreased mobility, anemia, immunosuppression, and thrombocytopenia. It may also affect cognitive functioning. Some interventions for patients receiving chemo. Important to monitor for side effects and toxicity. You're going to teach them ways to prevent infection as well as what signs and symptoms they need to report, including fever, bleeding, and bruising. You want to administer antiemetics. Very, very important. Sometimes the nausea and vomiting is so bad that patients will stop receiving treatment. Just like we do with pain, you know, we always say, stay ahead of the pain, you know, make sure you get that medicine before your pain gets out of control, because otherwise you're playing catch up and it doesn't really ever work. Well, that's going to be the same with the antiemetics. We don't want the vomiting to ever start. We want to pre-treat them. Really important to encourage fluids, teach proper oral hygiene, and refer them to community resources or assistance groups for wigs, financial assistance, and support groups. Some neutropenic precautions, not really sure if this is a facility-based thing or not. In my experience, at the hospital, we always used neutropenic precautions, and then in about the last 6 months or a year, they changed that and said that reverse isolation was no longer necessary. So never really been able to find any data to say it's not necessary, so I'm not sure where that decision came from. But the point is that this may be, it may be determined by your facility. So they may use them, they may not. Obviously, if they do use them, you're going to want to make sure the patient has a private room. Hand washing is extra important. Excuse me, sorry. You're going to check their temperature frequently and assess their skin and mucous membranes. You want to limit visitors to healthy people. You do not allow fresh flowers. So a low bacteria diet and the foods that are acceptable and not allowed. That is listed in a chart 22-4 on page 382. Basically, there is typically no fresh fruit or raw vegetables. That's an important distinction, guys. Fresh fruit or raw vegetables. So are baked vegetables going to be okay? Yes. It's the fact that it's raw. No meat, fish, eggs, pepper, or paprika. Do you guys remember how to figure the ANC? Once you total that up, normal ANC, again, for reference, is going to be greater than 1,000. These patients, I'm so sorry, I got a tickle. These patients that have neutropenia, they are at an extreme risk for sepsis. They oftentimes their infections are resulting from overgrowth of their normal flora that enters into the bloodstream. So, teaching for them is very, very important. We want them to avoid crowds, don't want them sharing any personal items. They need to bathe daily. Don't drink liquids that have been at room temperature for more than an hour. They need to clean their toothbrush daily and do not reuse cups or glasses without washing. I'm so sorry, y'all. Page 382 has chart 22-4 on it that goes more in depth into these. So now for thrombocytopenia precautions, you are going to want to use a lift sheet with these patients. You want to do whatever you can to prevent injury. So again, it's important to make sure that if you're getting them out of bed, if your tech's getting them up, they understand that they need to be using the gait belt. They need to have shoes in place before ambulating. Use the draw sheet, things like that. Those are very important. You want to avoid injections. You can apply ice to areas of trauma. You want to observe the urine and stool for blood. Measure the abdominal girth daily. Very important that they use a soft toothbrush and no floss. They aren't even supposed to use like the water picks or anything like that. Don't want them blowing their nose, and we're not going to take rectal temperatures. So page 383 has chart 22-5 that discusses these precautions. Your text talks about the actual count, and it said that when platelets are less than 50,000, small trauma can cause prolonged bleeding. When they're less than 20,000, spontaneous and uncontrollable bleeding can occur. So very important to monitor those labs and also to make sure we've got safety precautions going on. Some interventions, there is chart 22-6 on page 384 and chart 22-8 on page 386. So the patient that has mucositis, which is going to be sores in mucous membranes, is gonna obviously have very painful mouth that will affect their quality of life and their eating habits. So patient may use disposable mouth sponges. They can rinse their mouth with water or saline hourly. We want to avoid alcohol mouthwashes. They often have swish and spit or swish and swallow mixtures that they use, such as nystatin or magic mouthwash. They can rinse every 12 hours with half peroxide, half saline mixture. Lip care is important as well as denture care, and they may require artificial saliva. So the types of foods that are going to be best for these patients are warm, cool, and cold foods. You want to avoid hot foods. Soft foods are okay. Avoid hard foods. And then you want them to avoid spicy, salty, acidic, dry, and rough foods. So the thing that's hard with these patients is they may already be anorexic from just their treatment and things like that. Nothing sounds good. Their tastes have changed. And then on top of that, we're going to throw this mucositis in the mix where it just is excruciating for them to eat. So important to consider and important to protect that mouth health so that we can try to encourage eating as much as possible. Chemo brain, that is the reduced ability to concentrate, memory loss, or difficulty learning new info. Thought it was interesting that this does not affect everyone. The exact cause and risk factors are unknown, and it may occur during treatment and last for months to years. The priority for this patient is going to be some emotional support. They've got a lot going on just with their diagnosis, so I can imagine having chemo brain on top of that makes things that much more difficult. It's really going to be important to support them. So hormonal manipulation, some side effects of, oh, I think I skipped one, sorry. Some hormones that make, some hormones can make hormone-sensitive tumors grow rapidly. Some tumors do require specific hormones to even divide. So the goal with hormone manipulation is to decrease the amount of certain hormones so that we can slow cancer growth. Some side effects of hormonal manipulation. In women, you may see masculinizing effects. Chest and facial hair may develop. Their menstrual periods may stop. Breast tissue shrinks. They may develop acne. In men, they may have some more feminine effects appear. They may have facial hair that disappears or thins, and their facial skin becomes smooth. Their body fat is going to be redistributed. They may have gynecomastia, which is where they develop breasts, may develop acne, testicular and penile atrophy, and achieving and maintaining an erection can be difficult. Additionally, both men and women commonly have hypercalcemia and liver dysfunction as a result of hormonal manipulation. Something else that's really important to these patients is what they're at risk for. So all patients receiving estrogen or progestins are at increased risk of DVT, and that's important to keep in mind to monitor them for signs and symptoms. Photodynamic therapy is going to involve the destruction of cancer cells with a laser. It is most commonly used for non-melanoma skin cancers, ocular tumors, GI tumors, and lung cancers. With it, a light-sensitive agent is going to be injected. The agent enters all cells and leaves normal cells more quickly. I think it said in about 48 hours the agent is out of the normal cells and it's most concentrated in those cancer cells. And so they do localize in the cancer cells, and a laser is going to be focused on that tumor, and the light causes cell damage. So this can be used to destroy some cancers, and it will also reduce the tumor size. Oftentimes surgery will follow that. And it can relieve obstructions by shrinking tumors that, for instance, may be in the airway. So, some teaching for the patient. Before photodynamic therapy, they're going to bring protective clothing with them to wear home after the injection. They're going to need someone to drive them home. They need to avoid the sun, cover all windows, and replace their light bulbs in their home to low wattage bulbs. After therapy, they may be sensitive for 1 to 3 months to light. They need to drink a lot of fluids. Still want them to avoid sunlight and high wattage indoor light. Don't want them taking any new meds. Sunscreen is not going to prevent sunburn in these patients. And it's important for them to follow up with an eye doctor. So this is pretty hardcore. Even the use of a pin light can cause burns. A sensor on a pulse ox can also cause issues. So if they are in the hospital setting, you're going to turn electronic equipment away from them. You also want to consult the pharmacist because medication reactions may alter the sensitivity of an agent. The other issue is that a lot of medications actually cause photosensitivity. So with them having this light sensitive agent already in them may be an issue. Immunotherapy, BRM. So how does this work? Cytokines and other BRMs stimulate the immune system to recognize cancer cells and take action to eliminate or destroy them. This is going to include interleukins and interferons. Something that I do want you to know is these side effects. Edema can be life-threatening, fever, chills, rigors, malaise, decreased sensation, visual disturbances and decreased hearing, unsteady balance and gait, orthostatic hypotension, and skin rashes, dryness, itching, and peeling. So in general, it looks like they have got some flu-like symptoms. They're going to be at an increased risk for injury, and they're going to have some skin trouble. Other therapies, gene therapy is still experimental. One method renders the tumor cells more susceptible to damage or death. So you can insert a viral enzyme into a brain tumor, and that will make the tumor more susceptible to being killed. Or you can insert a foreign HLA genes so that the immune system doesn't recognize them and invades and attacks. Targeted therapy combines gene therapy and immunotherapy. All right, so most importantly here, for you guys as nurses, wherever you work, you're probably not going to necessarily be dealing with cancer patients for their cancer treatment unless that's something that you specialize in. More commonly, you're going to see these patients in the clinic or in the hospital setting because of complications or side effects related to their cancer. So it's very important to understand these oncologic emergencies. Sepsis is a huge one. It is a very common cause of death in cancer patients that are at risk because their white count is so low and their immune function is impaired. Prevention, again, is going to be key with these patients. Antibiotic therapy is going to be initiated really early on. Sometimes if a infection is suspected, the doctor may not wait until they have confirmation of that infection. They're going to treat prophylactically because they want to make sure these patients don't get septic. DIC is caused by sepsis, that's disseminated intravascular coagulation, and the release, so sepsis causes it, the release of clotting factors from cancer cells or blood transfusions. So what happens is abnormal clotting occurs in the blood vessels, and this clotting will use up all of those clotting factors out of the blood and also the platelets. So that in turn leads to extensive bleeding. Clots will block the blood flow to organs, and that results in pain, stroke-like symptoms, shortness of breath, increased heart rate, decreased output, and tissue death. Bleeding occurs everywhere and ranges from minimal to life-threatening. So I've never seen this in the hospital setting, but I can remember vividly the day that we learned about this in class because the teacher said, they're going to be bleeding from everywhere. They're going to be bleeding from their eyes, their ears, their mouth, their nose. Their skin may weep blood. So this is obviously a very serious and life-threatening issue. And in the case that there is this bleeding, clotting factors will be given to the patient to try to put a stop to it. So SIADH, syndrome of inappropriate antidiuretic hormone. This is very common in cancer patients. Water is reabsorbed by the kidney, which results in excessive volume, and that leads to hyponatremia. Some symptoms can include weakness, muscle cramps, decreased appetite, fatigue, weight gain, nervous system changes, personality changes, confusion, and ultimately leads to seizures, coma, and death. So treatment for this is going to be fluid restriction, increased sodium intake, and some drug therapies. For spinal cord compression, this can occur because of the tumor on a spinal cord or when there is degradation of the bone, which causes it to collapse and compress the spinal cord. Symptoms are going to be dependent on the location of compression, may include numbness, tingling, bowel and bladder problems, pain, and weakness. Treatment for compression is going to be palliative. Steroids may be given for reducing the inflammation. Radiation may be used, surgery, and sometimes they may wear neck or back braces. Hypercalcemia occurs most often in patients with bone mets. Cancer of the bone causes those bones to release calcium into the bloodstream. Fatigue, decreased appetite, nausea, vomiting, constipation, increased output, loss of deep tendon reflexes, ileus, dehydration, and EKG changes may occur. So treatment for that is going to be PO or IV hydration and the use of loop diuretics. With superior vena cava syndrome, the superior vena cava is compressed by a tumor. Symptoms, of course, are going to result from the blockage of blood flow. Symptoms may occur when the patient arises in the AM. Facial edema is going to progress to arms and hands as the condition worsens. And I believe there's a picture in this in your text at the end of the chapter. So signs and symptoms include nosebleeds, hemorrhage, cyanosis, mental status changes, decreased cardiac output, hypotension, and death will result as if there's no intervention. So treatment for this is going to be high dose radiation or chemo. Surgery may be used, but it is rare. And what they would do is they would go in and place a metal stent in the vena cava to try to help relieve some of that swelling. All right, guys, last one. So tumor lysis syndrome is good for a few reasons. It is a positive sign that treatment is effective. What happens is that a large number of cancer cells are being destroyed rapidly, so those are good things. However, the contents of those cancer cells are released really quickly into the bloodstream, and that's faster than the body can excrete them. So it can cause severe tissue damage and death. Hyperkalemia and hyperuricemia may result. As far as the amount of fluids that patients should consume, they need to consume 3,000 to 5,000 mils. So treatment for this, hydration prevents and manages this syndrome because it dilutes the serum potassium and it increases kidney flow rates. Diuretics may also be used, and meds that promote purine secretion may be given. So that's all I've got on here, guys. I hope that this was helpful to you. Again, I'm so sorry for the delay in getting it to you. If you have any questions or concerns, please feel free to reach out to me. And I hope you all have a wonderful weekend and good luck on your test next week.